Thank you for having me as a speaker. I'm just so excited to talk about this topic, as is my colleague, Michael Avidan. So let me share my screen and we will dive right in. So we're going to talk about a subject that is near and dear to my heart, which is leading multi-site perioperative pragmatic trials. So this is the talk I wish somebody had given me when I was starting off. So we're going to talk about kind of what we know now, what we wish we knew then. Michael and I have divided up some of these topics, and we're going to talk for about 40 to 45, 50 minutes, and then we'll have a Q&A afterwards. So I have no financial disclosures. I'm not going to reference anything off-label or investigational drug use. My grant support is from these organizations, both in the past and currently. And not surprising, it takes a lot of money to do these kinds of trials. So you do need grant support. So our objectives for the talk are to understand if and when a multi-site design will or won't help you. We want to also give you some tips for picking partners, designing your study, what should be your governance plan, as well as some of the nitty-gritty IRB, designing your trial, when to use a pragmatic trial, financial structuring, and then we're going to talk about kind of a time capsule for each of us, what we know now and wish we knew then. Let's dive in. So I also want to start with a case study because this can give you an idea for kind of the trials that we do. So at least for me, all of my research work is in advanced care planning and palliative care, specifically in critically ill and perioperative populations. I'm a critical care anesthesiologist and palliative care physician and researcher. And I don't think I need to tell you perhaps, but especially when I started this work in about 2008, 2009, it was absolutely the Wild West. There was pretty much no research in advanced care planning, much less palliative care in perioperative populations. So to give you an idea for the kind of work to build up to a large pragmatic trial, this is essentially my career funding that built up to our current trial. So I had a FAIR award from 2011 to 2013 that gave us foundational research that allowed me to submit for a single site trial, which was 2012 to 2017, which is funded by PCORI. That was essentially for a video-based advanced care planning tool, single site. The data from that then allowed us to submit, again to PCORI, to be able to fund a multi-site pragmatic trial. So this is the timeline for me, and it's not a rare timeline. These trials take years to build up. So absolutely do it. I encourage you to, but also kind of go in with your eyes open and know that this is a marathon, not a sprint, and that you build this over years. For me, this has been almost, over a decade, about a decade and a half. So this was our single site trial, which is in and of itself a lot of work. And so you're doing a single site trial, and we had a lot of publications from that. And it took this body of work to be able to submit to be successfully funded for a large pragmatic trial, so just getting expectations out there. So our current pragmatic trial is to compare surgeon alone versus surgeon palliative care team co-management for patients preparing for upper GI cancers. We're powered on patient-reported quality of life at 3 months post-op. This is actually the first multi-site RCT that's ever integrated specialist palliative care into the perioperative space. So there are 5 sites. And it's a $2.15 million contract. It's probably going to be even a little bit more. We were initially, I started submitting this a version of this in 2014, 2015. It was funded in 2017. I lost track. It was my 3rd or 4th time around with PCORI, and I'd submitted it to probably 3 or 4 other funders as well. And so we started funding in 2018, and we are due to be finished March 2023 with our funding. So yet again, perseverance is important for work like this. You often are not funded on the first time, the 2nd, the 3rd, the 4th time. So our 5 sites are Stanford, Johns Hopkins, the Dana-Farber, University of New Mexico, and the Ohio State University. So this trial is ongoing. As I record this now, we have 366 participants on our way to our goal of 380, so we are almost done. So that's an example. That's the large pragmatic trial that I'm running right now. I want to talk now generally about large pragmatic trials. And when you're thinking about it, what do you want to do? So this is kind of back to basics, but you really want to have this level of understanding as you're walking in. So first off, you're doing an RCT. What level are you going to randomize on? Are you going to randomize on the patient level, on the provider level, like cluster randomized by provider, or on the hospital or the site level, cluster randomized by site? What you do depends on your intervention. And it can depend on not just the intervention itself, but the state of the intervention at your own institution. So just to give an example, so we are studying specialist palliative care. When we first submitted this to our funder, we submitted it randomizing patients at the patient level. So a patient's either randomized to surgeon alone or surgeon palliative care team co-management. And the funder came back and said, actually, we want you to cluster randomize. And they said, we want you to cluster randomize either by surgeon or by site. So cluster randomizing by site, usually you need upwards of 12 clusters to have a trial. That makes sense. So suddenly we're a much, much, much bigger trial, a 12-site RCT. We went back to the funder and the funder said, no, we don't think we want you to be that big. They said, how about surgeons though? We want you to cluster randomize by surgeons. We specifically are working in patients pursuing curative intent surgeries for upper GI cancers. So our prototypical patient has pancreatic adenocarcinoma and they're going for like a Whipple or a distal pancreatectomy splenectomy. And when we looked, we did point out and said, you know, there's not a lot of surgeons who do these surgeries at each site. So each site might have only 1 or 2 or maybe 3 surgeons that do enough of these surgeries that we could cluster randomize. And the funder still said, hey, you know, we're concerned, but we actually then came and presented data. So these are data from one of our sites where we said, hey, these are our patients who would qualify for our study. These were patients pursuing surgery for pancreatic cancers. And we looked and we said, there is no penetration of our intervention in this population. So as you can see here, this was 107 patients who could have been enrolled in our trial. And they looked and actually tried to see who had palliative care, specialist palliative care consults. And out of the 107, only 1 patient. And that was when they'd been in the SICU for 2 months afterwards. So we actually used these data to go back to our funder to say there is no penetration of our intervention in this population when we are starting. One of our exclusion criteria actually is you can't have seen specialist palliative care beforehand. And we were able then to talk with our funder and to say participant level randomization is actually appropriate. So I hope this discussion helps you to understand that this level of randomization, it's not a given. You have to think about your intervention, your site, and your timeline. And you know, we sure could have done a cluster randomized trial by site with 20 sites to cluster randomize, but that would be a huge trial, and it was much more than we could have gotten funding for. So you have to find a middle road. And then also too, you really want to think about, is your trial explanatory or pragmatic? I'm really talking about pragmatic trials today, but there's still a lot of kind of misunderstanding between. So I just want to spend a moment on this. So explanatory is really an efficacy trial. Does X work? I am giving drug X. Does it have an effect on QRS? It's really looking at a cause and effect. You want a very rigid study design. You want to minimize all of the potential confounders that could get in the way of trying to figure out whether drug X works. You have very, very selective study inclusion. And it's very different than usual care. It is on a study and the outcomes are very relevant for research. That's opposed to pragmatic trials, which are effectiveness. Does this work in the real world? Should we be doing this? How does this interact with actual delivery of care? So broad inclusion criteria, really looking at effectiveness and how something works in actual practice. You want to maximize generalizability. So you want something that's very nimble. And the outcomes are really important, not for relevance to research, but does this work in real life? And if you're trying to figure out, hey, is my trial explanatory or pragmatic, this PRECIS 2 can be really helpful. If you give across these different axes that you can see on the rays here in the circle, you give your trial a score from 0 to 5. 5 means it's very pragmatic, and 0 means it's not. It's probably very explanatory. So like even just looking at eligibility, who is selected to participate in the trial? We have pretty darn loose eligibility criteria. We only have 3 essentially. So we're probably a 4, but a lot of, say, drug trials for a chemotherapeutic for a cancer population have very, very strict eligibility among histology and type of cancer and person and age and coexisting illnesses and such. So they may be 0. And you can actually do your trial like this. And I definitely have had colleagues who have used this to present their trial to funders on presentations to say how much of an explanatory versus a pragmatic trial. So you could see A is a very strong pragmatic trial, B is a very strong explanatory trial, and C and D are kind of in the middle. So this is just helpful for you to know about your trial, and so that you can explain it to funders and that you can have an awareness of it yourself. Now you got to choose your comparators, and you really do want to think very hard about this, particularly in pragmatic trials. So you want your comparators to be real life things. You want to be able to define them pretty clearly and such. I work in palliative care, so I work in complex behavioral interventions. I'm going to leave this alone a little bit. I think Michael Avidan's going to touch upon it a bit as well, but you just need to be very, very thoughtful about this and to define it pretty well. Outcomes, outcomes, outcomes. You live and die by your outcomes. That's why there's 2 exclamation points after it. You really need to think about this. They must be measurable. And if you can, validated outcomes are highly preferred. You can have an outcome that sounds like it should make sense and it should be measurable and it should be great for you. But has it been measured before? Are there outcomes that actually are validated that can show responsivity and discrimination? That's really important. And I'm going to show you an example. And if possible, you really want to look at the outcomes in your target population that you are going to be studying in your trial. You can do that through a pilot trial or from using a previous trial, and I'm going to show you because that's what I did, that used these outcomes in a similar patient population. So let's think about this a little bit because this is really important. So this is an example of a poor outcome. I do a lot of work in ICU-based palliative care. I did a systematic review on this topic, actually I've done 2, where we looked at different outcomes that people used. And one of the most common outcomes for a palliative care intervention in an ICU was people looking at family satisfaction. Is the family more satisfied with care or not? That makes a lot of sense. Good content validity. If you look at the different outcomes out there, like family satisfaction in the ICU or critical care family needs index, you look at the items and you're like, oh, this makes sense. This looks like a good outcome. But let's look at the data. So when you look at family satisfaction here, so these are, we had 21 different trials in the systematic review, 14 measured family satisfaction, but look at that. Only 1 showed any signal in it. It's a great outcome when you think about it, but the practicality of it is there's poor discrimination, there's poor responsivity in that outcome. So please just use this and anchor on this. Just because something sounds like it's a good outcome, it may not be a good outcome. You need to make sure that your outcome measure has responsivity and discrimination, because if it doesn't, it's of no use to you in a pragmatic trial. So what did we do? We used a previous trial. We used the outcomes from this Temel et al. Trial that was looking at specialist palliative care in medical oncologic patients. And we really took those outcomes and moved them into surgical oncologic patients. And we used some of the outcomes in our pilot trial. So we not only had the outcomes that had shown responsivity in this previous RCT, but we also had shown responsivity in our pilot trial. So outcomes are really important. So now you also want to think about IRB. So first off, now you may not need to think about it anymore, because if you're doing a multi-site trial and it's NIH funded and it's after 2018, now you need to use a single IRB. This is data from, or this is from the webpage of the NIH. If you're not NIH funded, if you're doing something else, then maybe you could use multi-site or multiple IRBs. We started our RCT in 2017 when we started with the IRBs. So in early 2018. So we are PCORI funded, not NIH. So we actually are multiple IRBs, but there's pros and cons to each. Do know it can take months to get through the IRB with a pragmatic trial. One of our sites, it took 14 months to get through the IRB. So just be ready, think about it beforehand. If your trial involves cancer patients, I do a lot of work in cancer, you often will have 2 IRBs. You will have a cancer center IRB and then your main IRB, and they don't work in parallel, they work in series. So that can take a while too. Do know that a lot of IRBs, they are built for explanatory efficacy studies. They are built for studies of that cancer chemotherapeutic. You are not what they're built for when you're doing a pragmatic trial, particularly like in a perioperative space. Like that is not what they are used to seeing. So, you know, be patient, be ready to educate them, go in with a big smile. You need to partner with them. They are an ally for you, but they're not used to seeing you. And this is definitely what it feels like. Welcome to heaven, enter here. Your trial's been funded. Yay. Oh, well, crap. Like they're not used to your trial and you now have to spend a lot of time educating your IRB and sometimes even your own institution about your trial. Consent. It can be written, verbal, there can be a waiver. What is acceptable can vary between institutions. So with the multi-site trial, just be very cognizant of that. And you may have slightly different consent approaches for different sites. You want to check with the regulatory groups at your institution as well as at every institution that you're working with. If you are the coordinating center, be very clear about what are the regulations at your site, at the coordinating center. If your site is not the coordinating center, then get to know that coordinating center. There's one site that's a coordinating center, and you very much are following all their regulations and practices. So just make sure that you know them. Okay, you can have a data safety monitoring plan, a data safety monitoring board. If I had given this talk 3 years ago, I wish somebody had given it to me, I would have said one thing. What you do depends on the risk of your intervention being studied. If it's very low risk, you can have either. If there's any risk at all, you could have your DSMB. Your funder may have regulations. Your institution may have regulations. A plan is something that you've written and saying, I'm following this. A board is a group of people that you have appointed who are going to watch your trial, and typically once or twice during your trial, look at data in an unblinded fashion to give you input. If you have a board, be very thoughtful in selecting your participants. You want them to know the type of work that you do. You get to choose them. So choose people who can be independent and give you good thoughts, but who understand your work. I work in palliative care in perioperative spaces. A lot of people misunderstand that. I'm a big advocate of having patient and family member advocates, partners on boards. They provide a really valuable insight. We could have a whole separate talk on that, but do consider involving them. If I could have given this talk to myself a few years ago, I work with very low risk interventions. I have a DSMP plan. I would have chosen now a DSMB board because I have a plan. We have a lot stronger regulatory oversight from some of the institutions that do not understand palliative care, do not understand pragmatic trials. And we have spent days and days, hundreds of emails explaining to them who we are and what we do. If I had had a board, I think I could have averted a lot of that. So look, you can learn from my scars. I wish I had done a board for my current trial, but you live and learn. So make sure your trial has a governance structure. This is actually important when you are getting your funding. So you want to consider the different members of your team and how are they organized? If there's a conflict, who's in charge? How are things structured? So this is the governance structure for our clinical trial. There's an executive committee. You can see I'm ahead of that. And this is when we only had 4 sites, and we have a whole structure at each site. That's a lead PI, a lead palliative care clinician, a lead surgeon, and a lead patient and family advocate. So just think about the governance structure. It's important for your funding, and it's important for the functioning of your trial. So you can see the executive committee, and then there's all the sites. Other possible advisory groups for you as you're leading these trials, you can have a steering committee, you can have stakeholder advisory boards. We have a professional advisory board with different professional organizations, such as the ASA, the American College of Surgeons, the American Academy of Hospice and Palliative Medicine, the Palliative Care Research Cooperative, the patient advocacy group, the National Coalition for Cancer Survivorship. So you can have a publications committee or group authorship guidelines, particularly if you're going to be writing a lot. It's good to define this beforehand so that there's nobody's toes that get stepped on. We already talked about a data and safety monitoring board as well. Okay, I'm going to spend a little bit of time on finances and legal. This is important. It is your business. Nobody knows your trial as much as you. And particularly if you have a trial that's gone on multiple years, like mine has, I am the only institutional memory for this trial. And you need to remember this. Your legal people may turn over multiple times. You are the only real source of project history often. To me, at least, this is the least able to be delegated task, keeping track of the finances. I have colleagues who have a wonderful finance manager that they've had that hasn't changed, and they don't have to think about that a lot. I am envious. That sounds wonderful. I've never had that. I've always had to do I don't do the finances, but I have to have an awareness and to keep track of them. So you really want to look at your subcontract invoices. You want to verify the numbers are correct, because once you send that money away, you can't bring it back. And sometimes the left hand doesn't know what the right hand's doing. So you may have negotiated a certain price amount with your site PI at that site, and somehow it got miscommunicated to their legal office, and their legal office invoices you for a different dollar amount. I can't even count how many times this has happened to me. It's not malicious. It's just, it's large, there's a lot going on, and things get lost in communication. So read every invoice. They're not hard. I typically get a couple invoices a month. It takes maybe about 30 seconds each, but you do want to keep track of it. direct and indirects. So remember, directs are what you can budget. That's the part of the budget that you own the money for. If you get a $1.5 million award, you can budget 1.5 million. But if you get a 1.5 million award, your institution will get that 1.5 million plus a certain amount of indirects. So usually it's like 30 or 40% depending on the funder. So the institution may get 2.15 million. And of that, you have 1.5 million that you can budget. The extra, that 0.75 million is the indirects that the institution takes for offices and lighting and such like that. But it can get very nuanced when you have a multi-site trial and subcontracts. Subcontracts get indirects too. Some of their indirects come out of your indirects, and some of their indirects come out of your direct, out of the money you budget. So they may get a certain amount of indirect, but it's coming actually from your direct as the site, main site budget. It differs by funders. It differs by the dollar amounts. Mine change after the first, I forget, like $30,000 or something. You need to read the fine print and work with your funders because this can be thousands of dollars and it can absolutely throw you off budget. Data use, so remember that. Data use agreements, this allow for data and PHI to pass between institutions. They're absolutely essential for multi-site trials. Just know they can take a while to arrange, and complex DUAs can complicate your regulatory reporting. We have one site that has a DUA that's really different than the others, and it's been problematic for multiple years, and we just know it. So just be aware of that. Funding. So you can have block funding where a site gets a certain amount each month, and that's what they get regardless of what happens. Or you can have milestone-based budgets where they get a certain amount based on completion of tasks. Like our trial, we enroll per enrollee. If a site gets an enrollee, they get 1,500 directs, which comes out to 2,100 with directs and indirects. That 2,100 comes out of my direct fund, but that's what they get. Or a task, like if you finish your IRB, you get a certain amount of money. Speaking from personal experience, I've done both. As a recipient, I like block funding because I know how much I'm getting. But as somebody who runs the trial, I very much like milestone-based budgeting because it allows me to actually attach my budget to deliverables and outcomes, and it allows me to stay within budget. So I strongly recommend milestone-based budgeting. Okay, finishing up, closing home. What I wish I knew then. Look at me, here's me over a decade ago. I look so innocent and happy. Little did I know how much fun and yet stress and goodness was coming as I became a leader of pragmatic trials. So what I know now and wish I knew then, trust but verify, even with friends, and you can be working with people you absolutely love. And I encourage you very, very strongly. These trials are huge. They're in a large amount of time. Don't do them with people you don't like. Do them with people you like, because you're going to interact with them again and again and again and again. And you want to go on this journey with somebody who's fun. So absolutely collaborate with people you enjoy. And even if they're people you enjoy and they're your friends, verify. Monthly enrollment audits, twice yearly missing data audits. People can have the best of intentions, but sometimes things don't just work out. As the person who's running it, know what's there and what's going on and just have that awareness. I already talked to you about directs and indirects. Read the fine print for what goes where for money. Know that you're going to do everything right and there's still going to be problems. Just accept it. Scaffold everything you can. Automate a lot of your trial design. So have there be weekly site project manager meeting agendas, minutes, updates. Just try to scaffold everything so that you don't have to think about it. It's just the way the system runs. So we have standing weekly meetings, standing weekly minutes. We have monthly audit things that just happen. And I've worked it out with my project manager, and it's great and it's important. Also, as you talk with your project manager, just accept if you're running a large pragmatic trial, you're always going to have some sort of regulatory documents due. You're always going to be under some sort of audit as soon as one ends, another starts. These aren't audits because you're doing something bad. These are audits just because you're running a large trial. They can be audits from your funder. They can be audits from your institution. They can be audits from one of the sub-site institutions. So just accept it. It's part of the ballgame. Keep experienced people close. We have multiple people on the trial who are kind of my 40,000-foot experienced person call. I really am close to some of them, and I'll phone a friend. I'll call them if I have any questions. You can't do this stuff alone. It's very complex. Have people around you who can help if you can. And know that if for your funder, the program officers can be really helpful allies. We have been so blessed. We have had wonderful program officers from PCORI the whole way through who have really helped us with a lot of our problem solving. And I'm so grateful for them. And then last thing, know that running these multi-site trials is hard. Being a child of the 90s, there's going to be Barbie days. If you remember the Teen Talk Barbie from the early 1990s, she said things like, math is hard, let's go shopping. And we definitely have days on our study where we're going, research is hard. We don't go shopping. We like to go out to eat, but of course, in a COVID land, instead we're going out for a long socially distanced walk, but just accept it. This is hard. There will be days that you feel demoralized. That's why it's important to go on the journey with friends and just embrace it. So the unexpected, expected challenges, you will have sites that are poor performers, and they can be wonderful people with the best of intentions, but accept it, it's going to happen. You will have staff turnover. It's very painful. Just be aware of it. I already talked about regulatory and compliance. There's going to be hurdles, there's going to be hiccups, and there's going to be times even when your experts don't know what to do. I've definitely called one or two of my key 40,000 foot, done this all, nobody knows more about these trials in the world than these people who looked and said, oh, I've never seen that. Oh, okay, let's figure it out. So there will be unexpected things, but it is really fun. And it's a privilege to do these kinds of trials. It's really contributing meaningful data for the world. And I'm so excited to be able to talk to you about them. If you have questions, please feel free to reach out to me, and we're going to have a Q&A afterwards as well. So thank you very much for spending a little bit of time with me today.
Hello, everybody. It is my great pleasure to be presenting at this year's International Anesthesia Research Society meeting. In particular, I'm delighted to be sharing a platform with my colleague and dear friend, Rebecca Aslakson, and also to be talking about a subject that is so interesting and so important about clinical trials and what I know now and wish that I had known before. Before getting into the talk, I would like to thank the many generous funding agencies that have contributed to some of the research that I will be talking about today. I have no financial conflicts of interest to declare. The NIH has a meeting on Fridays on pragmatic clinical trials and presentations of these called the NIH Collaboratory. And I strongly recommend that you try to attend some of these talks. Here is a very useful definition of pragmatic clinical trials, and one that I think is helpful in the design and assessment of a real-world pragmatic clinical trials that I have tried to incorporate into the research that I have done. Now, in thinking about how to pursue clinical research, the first thing that I would like to convey is that really it is most important to pick subjects that are important, and certainly importance to society is something to think about, but really what is critical is to pick a question that matters to patients, investigators, funders, society, but most importantly to you. And this has certainly guided my work and my decisions throughout my career as a clinical trialist. This is a painting from the 18th century, and it depicts what surgery was like prior to the advent of general anesthesia. And for this reason, and for many others, it is clear that the invention of general anesthesia in the mid-19th century was truly a Promethean event that signified a major transformation. To this day, general anesthesia is widely regarded as one of the most important advances in medicine that has allowed us to make huge strides forward. And in thinking about general anesthesia, one of the key points that we in anesthesiology consider is what are the perils of insufficient anesthesia, or anesthesia being too light. This slide, by the way, shows Charybdis, which is the whirlwind, and Scylla, the monster on the cliffs. And there were various times in Greek mythology, for example, Jason and the Argonauts, or Odysseus and his crew, who had to navigate between Scylla and Charybdis. And sometimes we in anesthesiology have to navigate between anesthesia that is too light or too deep. And that is pretty difficult to get that just right. I'm going to take you all back to 2004, when the seminal publication was published in The Lancet, the Be Aware trial. And in this trial, the investigators, Paul Miles, Kate Leslie, and others, found that if you implemented a protocol based on bispectral index monitoring, you could decrease the incidence of intraoperative awareness. But even then, I thought to myself, and I think that even more now, and this is the second important lesson, that a single swallow doesn't make a summer. And this is true of clinical trials. There are so often positive trials that have subsequently been refuted or have not replicated. So I was inspired by the Be Aware trial, and we designed the Be Unaware trial. These are some members of our team on the slide, and this is the journal in which the trial was published, the NEJM, in 2008. And for the Be Unaware trial, we randomized 2,000 patients who were either assigned to a protocol based on bispectral index monitoring or a protocol based on setting an alert for low end tidal anesthetic concentration. And all of the patients in this trial received anesthesia based on a potent inhaled volatile agent. And the third key lesson is that one swallow does not make a summer, even if it's your own swallow. So bear that in mind. Don't be in love with your own results, and be as skeptical about your own findings as you are about everybody else's. And also, you should utilize or leverage the findings of your research to do more studies. So in the Be Unaware trial, we actually found no difference in the incidence of intraoperative awareness with bispectral index monitoring or with a protocol based on end tidal anesthesia concentration. So we applied to the American Society of Anesthesiologists and the Foundation for Anesthesia Education and Research to conduct a follow-up, much larger trial over 6,000 patients called the BAG Recall trial. And in this trial, also published, you can see 3 years later in the New England Journal of Medicine. This time, we randomized over 6,000 patients, of whom about half were assigned to a protocol based on the bispectral index, and about half protocol where we set an alert at 0.7 age-adjusted MAC for volatile anesthetic concentration. And interestingly, we actually found, although this was not what we were assessing, but there were fewer patients who experienced definite intraoperative awareness, definite or possible intraoperative awareness, and distressing intraoperative awareness in the protocol based on end tidal anesthetic concentration. So this was now a similar finding to what we had found previously. So based on this, we were more confident in asserting that a protocol based on setting an alert for volatile anesthesia is unlikely to be inferior to that based on an alert based on the bispectral index for the prevention of intraoperative awareness. Of course, this doesn't have any implications for total intravenous anesthesia, since all of the patients in both the Be Unaware and BAG Recall trials received inhaled volatile anesthesia. It is important to mention that these trials could only assess intraoperative awareness with recall. So we know nothing about patients who might have been awake or aware during surgery, but didn't form explicit memories. And there have been subsequent studies done by Rob Sanders and others that have shown that it seems that approximately 5% of patients, of our patients whom we anesthetize, still have episodes of waking up or some degree of awareness during surgery where they follow commands like squeezing a ball with an isolated forearm, and where they don't remember that this happened. So they have intraoperative awareness, albeit without recall. So this remains an interesting challenge for our profession, if that is something that our patients and we would be concerned about. I'm now going to switch gear a little bit and talk about a different problem from intraoperative awareness. And this problem I've sometimes characterized as the orphan Annie problem of general anesthesia, which is post-operative delirium. Actually, I say it's a problem related to general anesthesia, but my feeling has actually shifted on this, and I think it's much more likely to be related to the trauma of surgery and of tissue injury and inflammation than it is to be linked to anesthesia and to the medications that we administer. But this is an active controversy and a subject that enjoys ongoing research. It seems that about 25% of older adults who undergo major surgery experience postoperative delirium. And this is not a good thing. Well, obviously, it's not a good thing. It's very distressing for patients, for their families. And also importantly, it's associated with negative outcomes, including other complications and even death. So it's been shown that people who have postoperative delirium are more likely to stay on the ICU for longer. They require longer mechanical ventilation, and the cost to the healthcare system is substantial. So we decided in, about 2013 or 14, that we would test ketamine as a possible prophylactic measure for postoperative delirium. Why did we think that this might be an interesting intervention? Well, a colleague of ours, Judith Huditz, had done a small trial in cardiac surgery patients in which she and her colleagues administered 0.5 milligrams per kilogram of ketamine following induction of anesthesia. And they saw a remarkable reduction in postoperative delirium from 31% to 3% in the group that received in this 0.5 milligrams per kilogram of ketamine. So we published our protocol in BMJ Open in 2014, and this trial was done on a shoestring budget with colleagues around the world, in the United States at Weill Cornell, in Canada, in Manitoba, in India, and in South Korea. This is Hannah Maybreyer, who was the lead investigator on this trial. And as I say, we really did this as a highly efficient trial on a shoestring budget, where we randomized just over 600 patients, and I'll show you what we found. But really, one of the next lessons that I want to emphasize is whenever I do a study or a trial, regardless of what kind of study, I try to publish the protocol. And I think that that's really important for scientific integrity. It holds us to a high standard and keeps us honest in terms of reporting what we had specified a priori. So I think that if you are considering pursuing a career in research, this is really a habit that I encourage you to develop. What did we find in this trial that we published in The Lancet in 2017? Interestingly, we found no significant difference. I should have added the word significant. You always find differences in trials, but often they're not statistically significant. So it's actually not accurate of me to say no difference. There was no significant difference in delirium incidence between patients who received the either of the ketamine groups. One group got 1 milligram per kilogram, one 0.5 milligram per kilogram, and one group got placebo, approximately 200 patients in each of those three groups. And interestingly, there were more patients with postoperative hallucinations and nightmares, and this was a dose-response phenomenon. So more so in the 1 milligram per kilogram of ketamine group than in the 0.5 milligram per kilogram of ketamine group, and in turn more than in the placebo group. Also, interestingly, we found no differences in any metrics of post-operative pain among these three groups, which went in the face of what people strongly believed, that a dose of ketamine of 1 or 0.5 milligram per kilogram would decrease post-operative opioid requirements or post-operative pain. So we really brought into question what was becoming a very common practice of administering intraoperative ketamine to prevent post-operative pain, and we certainly saw no evidence for the prevention of delirium. So negative trials, I no longer call them negative trials. I find them to be highly informative, and I rather think of clinical trials as either being informative or uninformative. And many trials that are ostensibly negative are actually highly informative. So I think recasting the way you think about trials as being informative or uninformative can be very helpful. Here are some of the team members from the podcast trial, and I want to highlight Ed Domino. Although he wasn't an investigator, Ed Domino died last year, but what a great pioneer he was, and one of the leaders in the application of ketamine to human beings. So I wanted to just mention his name and pay tribute to somebody who has inspired me greatly. Also pictured here are George Mashur, my dear friend and one of my closest colleagues and collaborators, Phil Velicities and Hannah Maybrian. So the next question that I'm choosing to highlight here is the question of whether deep anesthesia is deliriogenic. And we did a study, Bradley Fritz was the lead investigator on this, where we looked at 600 patients, and it was an observational trial. And we found that the more time that their EEG was suppressed during surgery, the higher the incidence of postoperative delirium. And there was a very impressive dose-response phenomenon. And the seventh lesson I wanted to share with you is that preliminary data are incredibly helpful, because we were able to leverage these preliminary data to get a trial from the National Institute on Aging to test this hypothesis. And this gave birth to the ENGAGES trial, which hypothesized that the avoidance of EEG suppression during surgery could prevent postoperative delirium. And here are some of the amazing members of the ENGAGES team. I can't mention them all by name, but suffice it to say, I loved working with all of them. And for me, team science and working with wonderful people is so important to research. And although I haven't highlighted that as a specific lesson, perhaps I should have done, because it truly is one of the most salient lessons for me as a researcher, and one that I'm certainly happy to share with all of you. So thinking back to Scylla and Charybdis, now we're exploring the Charybdis issue. If you get too deep with general anesthesia, do you run the risk of postoperative delirium? These are some EEG waveforms, and you can see suppression very easy to pick up on the EEG. It simply looks like a flat line trace, and that is when often you would get with excessive administration of anesthesia. This patient was on cardiopulmonary bypass at the time this photograph was taken. So here are the results of the ENGAGES clinical trial, which was published in the journal JAMA in 2019. There were 1,232 patients randomized, and in the EEG guided group, we were really able to substantially decrease the amount of time that patients spent with EEG suppression. We also decreased the average concentration of volatile anesthesia that was administered. Again, in this trial, all of the patients got an inhaled volatile anesthetic, but surprisingly, we did not find a decrease in delirium incidence among the patients who had EEG-guided anesthesia and a less of an exposure to general anesthesia. So this was pretty unexpected, but as I said earlier, one swallow does not a summer make. So even though these are our own results, we shouldn't be in love with them, and we need to have an open mind. So again, we want to leverage these findings and do a follow-up study. And there are problems with this ENGAGES trial. It was a single-center trial. Maybe it wasn't the right EEG signal. Maybe there weren't the right at-risk patients. So we decided to do a study collaborating with colleagues in Canada, and we, together with them, obtained a grant for ENGAGES Canada. I'm not going to speak more about that because I'm a collaborator and I'm not leading that trial, but suffice it to say that, again, you see examples of leveraging results here from a single center trial to conduct a multi-center trial. And ENGAGES Canada is enrolling patients having only cardiac surgery at 4 Canadian centers with the same attempt to avoid EEG suppression in the intervention group, and in the hope that we will prevent delirium after cardiac surgery. Finally, I'm going to tell you about the THRIVE trial, which hasn't yet started. It's been supported by the Patient-Centered Outcomes Research Institute. Here are the names of some of the team members involved in the THRIVE trial. Sachin Ketrapal and I are co-PIs on the trial, but you can see the most incredibly accomplished, eclectic, diverse group of investigators, including many patient partners who've had lived experience of general anesthesia and are helping us to conduct this trial. And just to give you a bit of background, I think that you all know that there are 2 main types of general anesthesia, inhaled and intravenous. And the primary intravenous agent is propofol, and inhaled agents, drugs like desflurane, sevoflurane, isoflurane. Here is a sevoflurane vaporizer. Inhaled anesthetics have been around since the mid part of the 19th century, so for about 175 years. And propofol has been around for over 50 years. John Glenn discovered it in the 1970s, won Alaska Prize for it. We've already spoken about how important the demonstration of ether anesthesia was in the 1840s. And today there are about 300 million people who receive general anesthesia every year around the world. About 80% in the United States receive an inhaled volatile anesthetic, and about 20% receive propofol total intravenous anesthesia. And surprisingly, although these techniques have been around for a long time, and despite the fact that this is a foundational question for our field, to this day, we do not know which of these 2 general anesthetic techniques is superior, which results in a better patient experience. We know that there are some advantages with total intravenous anesthesia, like decreased nausea and vomiting, and perhaps fewer side effects. We also know that inhaled volatile anesthesia is perhaps a bit more predictable and technically easier to administer. But look at all of these key gaps in our knowledge. We really need to answer which of these techniques is better with respect to awareness, cognitive recovery, sense of well-being, pain, ability to communicate, get back to a normal functioning as quickly as possible, enjoying sleep and food. Some really fundamental questions that we hope to answer with this THRIVE trial. And the THRIVE trial will be conducted at some of the sites shown on this map, all of which are participating in the multi-center perioperative outcomes group, or MPOG. And here's the thing. Before you jump into a large 12,500 patient clinical trial, you should really do a pilot feasibility trial first. And that is exactly what we're planning to do with THRIVE. So before we do this massive trial, we're going to conduct a 300 patient feasibility trial. And the lesson I want to convey here is that feasibility trials do not test efficacy or provide provisional data regarding efficacy. They are done for feasibility, to see if it would be possible to do the trial. So what we're going to be doing is randomizing 300 patients in 2 centers where we'll be tracking the outcomes that we will be looking at in the THRIVE trial, but we're not seeking to see if there is an effectiveness or efficacy signal. So we're not really looking if one of the techniques improves quality of recovery or is associated with less awareness than the other. What we are trying to find out is if we can enroll enough patients. So we feel that success, what would success look like in this feasibility pilot? It would mean that more than 10% of the patients whom we approach agree to participate. It would mean that more than 80% of the patients enrolled to the trial in either arm receive the type of anesthetic that they are randomized to receive. Because if you cannot deliver the intervention, then that will not be a success. And then the third metric of success is to ensure that we're able to collect more than 90% of the outcome measures that we need for the trial. So I will just summarize that by saying there are 3 areas in which clinical trials fail. And those are recruitment, inability to deliver the intervention with fidelity, and inability to have comprehensive outcome ascertainment. If you can do those 3 things, you can generally conduct a successful clinical trial. What I also wanted to highlight is the importance of putting the patient at the center of everything that we do. And this is something that we're going to be implementing with real energy in the THRIVE trial. And we have patient partners who are infusing every aspect of the trial and are participating intellectually and with gusto in the THRIVE trial. So I also thank them, and I'm so excited to work with so many stakeholders, including surgeons, all members of the anesthesia team, and hospital administrators, and people within society, and of course, the patient partners who have been so central to what we've done with the THRIVE trial. I'd like to finish this brief talk with a quotation from Milton. I see anesthesiologists as clinical neuroscientists, and in the poem Paradise Lost, Milton says, "The mind is its own place, and in itself can make a heaven of hell, a hell of heaven." Thank you very much for listening to what I have had to say. Rebecca and I will be delighted to take your questions.
There's a question from Dr. Sheldon Goldstein. We're a small enough group. Do you want to ask your question, Dr. Goldstein?
Yeah, sure. In the ketamine trial you conducted, was there an obligation to give benzodiazepines to patients before they received ketamine? Because I wonder if that would influence the frequency of delirium as a post-op outcome.
It wasn't required, but most of the patients did receive midazolam routinely regardless. That's the answer to the question. I'm not convinced that benzodiazepines have really been rigorously shown to prevent hallucinations and nightmares following ketamine, although that is established wisdom. I'm not sure that the evidential rigor behind that is very strong. We have a question from Miles Berger. Miles, good to see you. Do you want to ask your question?
Oh, sure. Yeah, 2 questions. One for you about, or you and George, if George is on too, regarding podcasts. Have you guys done any sub-analyses looking at whether ketamine's effect on delirium differs depending on patients' baseline cognitive status? And then the other one is whether its effect on pain differs depending on whether the patients were taking opioids before surgery or not.
So both good questions. And in really the problem with sub-analyses is doing them post hoc, you're going to have lower numbers and there'll be hypothesis generating. So we haven't looked at either of those questions specifically. And I don't think that we would have enough numbers even to meaningfully generate hypotheses. I think they're good questions, but I don't think that the trial is adequate to address them.
And then thank you. And then the other question was for both of you. What would you say are the best ways to ensure fidelity to an intervention across sites when you're doing a multi-site study?
I mean, first off, some of these things you're actually measuring, they're almost implementation studies. So pragmatic trials are about real world. So if it takes a lot to be able to implement them, is this really what you are measuring? Is this the right trial for you? So rather than fidelity, like for our trial, we just need to know that it happened. Like, did people in the intervention arm meet with specialist palliative care? How often did they meet? And then we actually, rather than intervention fidelity delivery, we actually, at the very beginning, we went through a real mental gymnastics about, do we heavily protocolize the palliative care that we're giving and people are working from a script, or are we saying it's specialist palliative care? These are all trained subspecialists, they need to do it. One of the trials, which is Carson's et al. That was published in JAMA in 2016 in like August, did a very protocolized palliative care delivery for chronically critically ill patients in the ICU. And it actually was, I know people at the sites who did it who said it was horrible to do it very protocolized, because a lot of what specialist palliative care is adjusting to the patient who's in front of you and being there with the right intervention for that person at that time. Some people are ready to talk about prognosis, some people aren't. And if you heavily protocolize it, you're actually detracting from what palliative care specialists do. And so with that, we did not heavily protocolize the intervention. And instead we're saying, are people doing palliative care? And then instead, what we're doing is we are doing surveys after every interaction with a palliative care specialist. They then do a survey that said, what's in the syringe? What did I actually do? Did we talk about symptoms? Did we talk about this or that? This has actually been validated with other palliative care trials. So then you look at your effects and then you could say, okay, this is then what was done to get those effects. And I'm gonna go to Michael then, because I think he will have some different answers, but you have to really think about, what does intervention fidelity mean in relation to what you're trying to find as far as generalizability, and what is your actual intervention?
Thanks, Rebecca. So I agree entirely that you can't do a pragmatic trial if your intervention needs to be forced like a square peg through a round hole. It has to be something that is practical to do in the real world. And the way I think about this in a feasibility trial is that you really are trying to assess whether or not the intervention does work in the real world. So in the instance of the Thrive trial, which we will be conducting as a feasibility trial at 2 centers, our intention isn't to police people and try to coerce them, but rather to see whether you can have enough people doing true TIVA and true inhaled anesthesia such that a large pragmatic trial can be done successfully. So if I didn't explain that adequately, I'm glad the question was asked to allow some clarification on that.
Great, it looks like Liz Whitlock has a question. Liz, do you want to ask real quick?
Actually, I've got a bit of laryngitis, and so I've put my question in the chat. That's okay.
That's fine. I'm going to read it for you then. I wanted to acknowledge your presence. I'm sorry about your laryngitis. Dr. Whitlock says, could the panelists comment on getting the most mileage out of a trial? Michael and Miles's question hinted at this with the palette of secondary outcomes in podcasts and now in Thrive. Are there ways you think about how to squeeze the most knowledge out of a large pragmatic trial? We call this stealth science. There's what you submit and what you're funded for, and then there's what you also do while you're doing that. So like right now, we are doing a host of secondary outcomes that have never been studied in this patient population that are exploratory. But like, what is the entire perioperative symptom experience like from pre-op up to 6 months post-op? We are incredibly interested in that. You know, what's spiritual distress? What's psychological distress? What's prognostic awareness? So for me, this is something that you think about with your secondary outcomes. Michael, your thoughts?
My thoughts are, it's a bit of a double-edged sword, Liz, and I'll tell you why it's a double-edged sword. There is a real temptation. You want to specify what you're going to do. So there's a real temptation to put a laundry list down in your protocol or in clinicaltrials.gov, but then you really have to do all of those things. So you can't say, we'll put this laundry list and then we can pick from the list which we actually want to do. You can, I guess, do whatever you want post hoc and use that for hypothesis generation, but then it really is a soft, it's pretty soft what you're doing. And you have to be careful about that, which is what I was answering to Miles, that we can do any secondary analyses we want and we can torture the data as much as we like. But the temptation to overinterpret what you do from that is great, and I think should be resisted. I think it is best to be thoughtful about your primary and secondary hypotheses, to put down what you really think you'll be able to do, and to recognize that there's a lot of richness in that. If you look at many trials that have been done, I think that you'll find that many have thoughtfully put down primary, secondary analyses and other even other analyses that will be done using the data for observational purposes. And most clinical trials are able to yield quite a few good publications that way. So my recommendation would be not to just use your imagination and run rampant and put down everything you can think about, but also to try to be thoughtful ahead of time, because so much about the success of a clinical trial depends on what you do early on. It's the preceding 2 years before the trial launches that determines how much impact you will have with the trial. It's all the work that you do ahead of time.
Yeah, and I would say too, thinking about, and I we're doing a lot of descriptive work with these outcomes. It's not is something that we're going to do with the intervention changing them. It's probably regardless of the intervention, what is the situation, and that will be preliminary data for future work. And we haven't mentioned it, but I'd encourage you to think about mixed methods work, because that's often how you are figuring out what's actually happening in the real world. It's very illuminating. It's a lot of hypothesis generating. So almost all the work I do may be, yeah, there may be the quantitative, for clinical trial that's right there in what everybody sees that's got quantitative outcomes, but there's always a qualitative layer. So we're actually, as of Friday, 377 on our way to 380. So we're almost done with enrollment. But in the midst of, I know, yay, so many headaches. But in the midst of that, we've done 70 interviews with patients, families, and perioperative providers to better understand what's actually happening. And that's all data for what's going to come next and such. I know we're a little past time, but happy to take more questions, happy to talk about this. As I'm sure you maybe got, these are labors of love. You're never paid a lot to do this. And I have to remind myself that the headaches and the heartburn and the nausea is worth the outcome sometimes. We've had a lot of Barbie days lately, if you haven't gotten the feel. So. Looks like this. Oh, Stephanie Robinson says, thank you. You're welcome, Stephanie. Or sorry, Stefan. Sorry, I read too quick. Dr. Robinson, thank you. You're welcome. Great. Well, Michael, all you.
Well, there was just one other question over here. Any data on the use of benzos regarding dysphoria? We didn't look at dysphoria, but we did do a logistic regression with benzos in the podcast trial and found no modifying effect on delirium with benzodiazepines, which was something we had pre-specified. So although I know that I left Dr. Goldstein feeling somewhat unsatisfied because we didn't do the analysis requested there, at least in terms of delirium, we did pre-specify and did do an analysis looking at a modifying effect of benzos and found none.
Mm-hmm.
But in terms of dysphoria, hallucinations, and nightmares, we did not answer that question.
Dr. Avidan, could I ask one more question along those lines?
Of course.
Anytime I've seen severe delirium, it's been a handful of times in my career, I've gone to Haldol. And yet I don't know that I've seen any studies looking at Haldol prophylactically to prevent delirium. And I guess people are concerned about extrapyramidal effects.
They exist in the ICU. Perioperative, I defer to Dr. Avidan, but there are studies about prophylactic Haldol, particularly in the frail elderly with hip fracture and trying to prevent delirium. And I haven't looked at the data in the immediate past, but it's not terribly exciting. And I'm an ICU doc. I use a lot of Haldol too, just because there's not a lot that's there. But I wish there was more supportive data about it.
It's a very good question. And so far, most trials to using drugs to prevent delirium, including haloperidol, quetiapine, melatonin and melatonin type derivatives, dexmedetomidine, have been pretty, have not been very impressive. I wanted to say have failed spectacularly, but I thought maybe that was a bit melodramatic and I should understate it a bit. I think that one of the challenges with delirium and what you refer to as severe delirium is that many people who have severe delirium are not very impressive in how they present. So many people who have the severest forms of delirium are pretty obtunded, they're withdrawn, they're hypoactive, and they're not the patients who are kicking and screaming and getting out of bed for whom we would be administering the haloperidol. And the challenge is that people tend to switch between both these forms of delirium so that it is even possible that some of the drugs we administer would worsen these hypoactive forms of delirium. So in trying to prevent hyperactive delirium, we might have an unintended consequence in relation to the fact that delirium is a spectrum disorder. It's not just a single simple condition. And I think that plays into one of the reasons why it's been very difficult to use a single magic bullet to prevent delirium. The interventions that have worked to prevent delirium have mostly been behavioral, and so far nothing has been tested and shown to succeed in treating delirium. And this has been identified as a major priority area for research by the National Institute on Aging and by various other groups. So the question you ask is very relevant, but I don't think that anybody will be able to give you a very satisfying answer.
Great. There's a question from Dr. Humaydan in the chat. Dr. Maiden, feel free to come off mute if you'd like to ask it yourself.
Sure, thank you. I so enjoyed getting to hear the experience of both of you. I think that's just such a valuable way to learn. And I was wondering, you know, in the future, I'm becoming more aware of implementation scientists and the folks that are actually studying, you know, the details of the implementation process. And I was wondering if you could just say a few words about the importance of collaborating with those folks for trial design and implementation.
Great. Well, first off, that's a really great question. And I encourage you offline to reach out to me. It's my email. Aslakson is just my last name at Stanford. I'm happy to have a longer conversation. Michael, you want to take the first stab at this?
You go ahead, Rebecca.
Oh, no. Okay. Well, I got to say, I think nobody makes better implementation scientists than research-oriented clinicians. This is like absolutely the zone. If you are somebody who really loves clinical work and maybe even wants to have a heavier clinical load, implementation science, where it's really about implementation of the knowledge that we have and how does it work in the real world, is a great place to be. And it's a spectrum. There are people who are true 80% researchers, lots of grant support implementation scientists that are running big implementation-like trials, running the spectrum all the way from folks who are 80% clinical, who are trying to implement ERAS in their own institution, but I'm always trying to push them to do it in a methodologically rigorous way so that you're collecting data and actually doing implementation science. So first off, I think it's really important. Secondly, there is a methodology to it. So find people at your own institution, find people who are true method implementation scientists who can talk about different conceptual models. There's nothing more important in implementation science than conceptual models and why something is supposed to work. So really partner with those folks. And if it's something that you like, become that person at your institution. Lean into that content expertise. And you could be that for your own department, but also across your institution. We need more people like that. And it's actually a great handhold career with patient safety if you're interested in patient safety.
Thank you. That's super helpful. Thank you.
Michael, anything you want to add on that topic?
No, that's a great answer, Rebecca.
I think we have one more question in the chat as well. For you, Michael, it's Dr. Pedamonte. Feel free if you'd want to ask it. I don't know if he is still here, but are you considering to include TCI propofol administration in THRIVE trial also?
We are considering everything at this point because the design hasn't been finalized of the THRIVE trial, but it is unlikely that we will implement. I think this speaks to Rebecca's point about something that is pragmatic. It would seem wrong or to implement something that isn't currently available or utilized in the United States. So that doesn't seem to be within the spirit of what would be pragmatic, because then we would do a study answering a question that didn't have direct applicability to clinical practice in the US. So although there are strong proponents of TCI who think that it is the only way to administer total intravenous anesthesia, it is not the way that total intravenous anesthesia is currently administered in the United States, and therefore it is probably not the route we will follow unless there is a sea change and Steve Schaefer and others are successful in getting TCI approved by the FDA in time for the THRIVE trial, because there is a strong lobby of people who feel that we should be. Why should we in the United States not have access to TCI when others around the world do and swear by its utility? So important question, and one that makes me squirm a little bit, but I've answered you honestly nonetheless.
I see your note in the chat, Dr. Pedamonte. Is there anything else you want to add verbally? Otherwise, we have to finish in 1 minute. And great.
I'm good, thanks. Thanks for your answer.
Great. Great. Well, everyone, thank you so much for attending our session. As I've already put my email in, if you have questions, particularly if there are budding clinical researchers, budding perioperative clinical trialists or implementation scientists, please reach out. You need a network. And I mean, I think I speak for Michael that we're both happy to be part of the network that you might have, particularly as you're starting to spread your wings. But it's important work to do, but it is hard work to do. And it's great to have people in your cheer box. Thanks, everybody.